patient in cardiac arrest presents with pulseless ventricular tachycardia. The first recommended shock energy for a biphasic defibrillator is A. 100 J, B. 120 to 200 J, C. 300 J, D. 360 J. Answer, B. The ACLS 2025 guidelines recommend using 120 to 200 J biphasic energy as the initial shock for VF/pulseless VT. The exact dose depends on the manufacturer, but starting in this range increases the chance of successful defibrillation while minimizing myocardial injury. During high-quality CPR on an adult, the correct chest compression rate is A. 60 to 80 per minute, B. 90 to 100 per minute, C. 100 to 120 per minute, D. 140 per minute. Answer, C. High-quality CPR requires compressions at a rate of 100 to 120 per minute with adequate depth, 2 to 2.4 inches. Going too fast reduces filling time, and too slow reduces perfusion. Which of the following rhythms is shockable according to ACLS guidelines? A. Asystole, B. Pulseless ventricular tachycardia, C. Pulseless electrical activity, D. Sinus bradycardia. Answer, B. Only VF and pulseless VT are shockable rhythms. Asystole and PA require high-quality CPR, epinephrine, and advanced airway management but no defibrillation. In adult cardiac arrest, epinephrine 1 mg 4/IO should be administered every A. 2 to 3 minutes, B. 3 to 5 minutes, C. 10 minutes, D. Only once. Answer, B. ACLS guidelines recommend 1 mg epinephrine 4/IO every 3 to 5 minutes during cardiac arrest. Early and repeated doses improve coronary perfusion pressure and increase the likelihood of ROSC. After return of spontaneous circulation, ROSC, the target oxygen saturation, SpO2, should be maintained at A. 85 to 90%, B. 90 to 95%, C. 92 to 98%, D. 100% continuously. Answer, C. Post-ROSC care focuses on preventing hyperoxia and hypoxia. The recommended SpO2 is 92 to 98%, as continuous 100% O2 may cause oxidative stress and worsen neurological outcomes. Which drug is the first-line antiarrhythmic for refractory VF/pulseless VT? A. Adenosine, B. Amiodarone, C. Atropine, D. Magnesium sulfate. Answer, B. Amiodarone 300 mg 4/IO is the preferred antiarrhythmic for refractory VF/pulseless VT. A repeat dose of 150 mg can be given. Lidocaine may be considered if amiodarone is unavailable. Which is the most reliable indicator of high-quality chest compressions during CPR? A. Audible click of compression device, B. End tidal CO2 greater than or equal to 10 mm of mercury, C. Chest compression fraction of 40%, D. Use of mechanical CPR devices. Answer, B. Capnography with EtCO2 monitoring is the most reliable feedback. A persistent EtCO2 less than 10 mm of mercury indicates poor compressions or poor prognosis. Good CPR should generate greater than or equal to 10 to 20 mm of mercury. When performing CPR on an intubated patient, the correct ventilation rate is A. 8 to 10 breaths per minute without pauses and compressions, B. 12 to 15 breaths per minute with compression pauses, C. 6 breaths per minute with 5-second pauses, D. 20 breaths per minute continuously. Answer, A. For intubated patients, ACLS recommends 8 to 10 breaths per minute with continuous chest compressions, no pauses for ventilation. Excessive ventilation can decrease venous return and cardiac output. A patient with unstable bradycardia is not responding to atropine. The next recommended intervention is A. Defibrillation, B. Transcutaneous pacing, C. Lidocaine 4, D. Carotid sinus massage. Answer B. For atropine refractory unstable bradycardia, transcutaneous pacing is indicated. If pacing is unavailable, dopamine or epinephrine infusion may be used. During adult cardiac arrest, the compression-to-ventilation ratio for a patient without an advanced airway is A. 10:1, B. 15:2, C. 30:2, D. Continuous compressions with one breath every 6 seconds. Answer C. Without an advanced airway, CPR uses a 30:2 ratio. This ensures adequate ventilation while prioritizing circulation through chest compressions. A patient with chest pain has ST elevation on ECG. What is the preferred reperfusion strategy if PCI is available within 90 minutes? A. Fibrinolytic therapy immediately. B. PCI, angioplasty, within 90 minutes. C. Anticoagulation only. D. Delay treatment until cardiac enzymes confirm MI. Answer B. For STEMI patients, PCI within 90 minutes is the gold standard. Fibrinolytics are considered only when PCI is not available within 120 minutes. Which medication is recommended for torsades de pointes associated with prolonged QT? A. Amiodarone, B. Adenosine, C. Magnesium sulfate, D. Atropine. Answer C. Magnesium sulfate 1-2G4 is first line for torsades de pointes. Amiodarone is avoided as it may worsen QT prolongation. When is atropine indicated in ACLS? A. For pulseless ventricular tachycardia, B. For asystole, C. For symptomatic bradycardia, D. For ventricular fibrillation. Answer C. Atropine is the first-line drug for symptomatic bradycardia, 1 mg for every 3 to 5 minutes, up to 3 mg maximum. It is not used in asystole or VF. Which of the following improves survival after cardiac arrest the most? A. Early administration of antiarrhythmic drugs. B. Early high-quality CPR and defibrillation. C. Early advanced airway management. D. Rapid 4 fluid administration. Answer B. The greatest survival benefit comes from immediate CPR and early defibrillation. Drugs in advanced airways are supportive but less impactful if CPR/defibrillation are delayed. The first action when you find an unresponsive patient with no breathing and no pulses. A. Give 2 rescue breaths. B. Begin chest compressions immediately. C. Attach an AED/defibrillator. D. Check carotid pulse for 30 seconds. Answer B. Once pulselessness is confirmed within 10 seconds, CPR with chest compressions must start immediately. Delays reduce survival. AED should be attached as soon as available. Which rhythm is most commonly associated with sudden cardiac arrest in adults? A. Asystole, B. Pulseless electrical activity, C. Ventricular fibrillation, D. Sinus tachycardia. Answer C. Ventricular fibrillation is the most common rhythm seen in sudden adult cardiac arrest. It requires immediate defibrillation for survival. Which drug may be considered for refractory VF if amiodarone is unavailable? A. Lidocaine, B. Atropine, C. Digoxin. D. Adenosine. Answer A. Lidocaine is an alternative to amiodarone for VF/pulseless VT if amiodarone is not available. Atropine and adenosine are not indicated. The H's and T's in ACLS are used to A. Remember reversible causes of cardiac arrest. B. Classify arrhythmias. C. Determine oxygen saturation targets. D. Identify post-ROSC care strategies. Answer A. The H's and T's mnemonic identifies reversible causes of arrest, including hypoxia, hypovolemia, hypothermia, acidosis, toxins, tension pneumothorax, thrombosis, cardiac/pulmonary. Which advanced airway device provides the most reliable ventilation during ACLS? A. Oropharyngeal airway. B. Bag mask only. C. Endotracheal tube. D. Nasopharyngeal airway. Answer C. The endotracheal tube is the gold standard for airway control. It secures the airway, prevents aspiration, and allows controlled ventilation with capnography monitoring. When performing synchronized cardioversion for unstable atrial fibrillation, the recommended energy is A. 50 to 100 J biphasic. B. 120 to 200 J biphasic. C. 300 J biphasic. D. 360 J monophasic only. Answer B. For unstable atrial fibrillation, synchronized cardioversion at 120 to 200 J biphasic is recommended. Lower doses may fail, higher doses are rarely needed initially. Which sign best indicates effective ventilation during resuscitation? A. Chest rise with each breath. B. Loud air leak around the mask. C. Gasping by the patient. D. Audible breath sounds without chest movement. Answer A. The best sign of effective ventilation is visible chest rise. Air leaks or sounds without chest movement suggest inadequate ventilation. A patient develops wide complex tachycardia with a pulse and is unstable. The immediate treatment is A. Defibrillation. B. Synchronized cardioversion. C. Adenosine 4-push. D. CPR only. Answer B. Unstable tachycardia with a pulse requires synchronized cardioversion. Defibrillation is used for pulseless rhythms, not when a pulse is present. For adult CPR, chest compressions should be performed to a depth of A. 1 to 1.5 inches. B. 2 to 2.4 inches. C. 3 inches minimum. D. 4 inches. Answer B. Correct depth is 2 to 2.4 inches, 5 to 6 centimeters, for adults. Too shallow reduces perfusion, too deep increases injury risk. In post-cardiac arrest care, targeted temperature management, TTM, is indicated for comatose patients at A. 32 to 36 degrees Celsius. B. 38 to 40 degrees Celsius. C. 28 to 30 degrees Celsius. D. 40 to 42 degrees Celsius. Answer A. TTM is recommended at 32 to 36 degrees Celsius for comatose patients after ROSC to improve neurological outcomes. Hyperthermia worsens brain injury. Which monitoring tool is essential for confirming endotracheal tube placement in ACLS? A. Chest X-ray. B. End-tidal CO2 waveform capnography. C. Pulse oximetry alone. D. Visual chest rise. Answer B. The most reliable confirmation of endotracheal tube placement is waveform capnography. Pulse oximetry and chest rise are supportive but less accurate.